Good evening, everyone. Welcome to tonight's meeting of the Health and Social Care Scrutiny Review Group. If I just go through the admin stuff first, this meeting will be live streamed to the public. Whilst you're moving around the building and in this room, if you wear face masks, but you can remove them when seated. A recording of this meeting will be available within 24 hours of the meeting. Remote participants joining the meeting using Teams, please turn your cameras on and use the hands up icon to indicate a question or comment. And for everyone, turn microphones on to speak and off when finished. Yes, yeah, that applies to everyone. Yeah. Okay, I think that's it. We go into the agenda. Apologies for absence.
Chairs, we get apologies from the councillors Adris, Agbar and Campbell.
Thank you. Minutes of the last meeting. Are we okay with the minutes of the last meeting? Take that as a yes. Disclosures of interest. Urgent business. Under urgent business, we have the Blmk Integrated Care System Establishment Report. If we can take this after the chair's update, if everyone's okay with that. References from committees and other bodies first.
None, Chair.
Thank you. Okay, chair's update. Just the one item. I hope all members have had a chance to read the item from ELF about the CMHS units. I believe there is someone from ELF to answer any questions that you might have about this. Does anyone have any questions or comments on the item?
Yes, Chair, we have Eugene Jones who's present, if there are any questions for him.
Okay, if I have one question for Eugene. There was a six-month gap between the decision that this decision was made and when this group was informed of that decision. Is there a reason why for that delay?
Yeah, thank you. There's a bit of an echo. Yeah, that's better. Thank you. Can you hear me?
Yes, we can.
Thanks. Yes, apologies for that. I think the reason for that is that in terms of the actual development itself, it's taken some time to work through the feasibility, if you like, in terms of finding a site, but also the financial elements in terms of actually resourcing the unit going forward, which were quite intricate and difficult to resolve. Appreciate we could have and we should have advised you at an earlier point in time, but as soon as we'd resolved those issues to really establish that we could move forward, we did advise you, which was prior to Christmas. Up until that point, we were discussing the possibilities, but we hadn't actually had any firm commitment in terms of the financial modelling to deliver that service. And so it was something which was a potential, but certainly not at any stage prior to that confirmed. So we could have and we should have advised you of those preliminary discussions. Apologies for that. But as soon as we had confirmed that we could move forward, we did advise you just prior to Christmas.
Okay, yeah, thank you for that. Yeah, we look forward to updates on progress in the future. Thank you. If we go back to item 4.1, the Blmk Integrated Care System establishment, I believe that's Nikki.
Yes, Chair. Can I introduce my colleague Maria Wogan? And I'm going to hand over to Maria to start with, and then we'll do a bit of a double act, and we may even bring in Carolyn, our exec lead on the place board for Luton.
Thank you. Thanks, Nikki. Thanks, Chair. My name's Maria Wogan. I'm the Programme Director for the establishment of the ICS in BLMK. And the paper that we've prepared for your meeting today is really a briefing paper of where we've got to in terms of our work across the system in getting ready to establish the ICS and the new ways of working that will come in when the Health and Care Act is passed. So the first thing I should probably say is that, as members are probably aware, there has been a delay in terms of the legislative timeline for the Health and Care Act. We were expecting that we would be establishing the ICS and all its constituent parts on the 1st of April this year, but now the target date for that is the 1st of July. Obviously, that is still subject to the parliamentary process, but that is the target date that we're working to. As I said, this paper's here for members to provide a briefing in terms of what the different elements of an integrated care system are and how that is shaping up in Bedfordshire, Luton and Milton Keynes, because all ICSs are different. We have certain statutory requirements to make, but we develop our local arrangements together. And this is how things are shaping up within Bedfordshire, Luton and Milton Keynes. So I'll just briefly go through the different elements and then happy to take any questions from the committee. The first part is the Integrated Care Partnership, which is in statutory terms a joint committee between the 4 local authorities in Bedfordshire, Luton and Milton Keynes and the Integrated Care Board once it is established. So in governance terms, we will need to bring the terms of reference for the Integrated Care Partnership through your council's executive and decision-making processes to get those terms of reference agreed and to enable that statutory joint committee to be established. The purpose of the committee is to set the population health strategy for the population of Bedfordshire, Luton and Milton Keynes, very much building on the work of the health and wellbeing boards in the 4 places. So there's a really critical relationship between the health and wellbeing boards and the Integrated Care Partnership. And it's about the Integrated Care Partnership building on the strategies developed locally and seeing what could be done to improve the outcomes for our population at that Bedfordshire, Luton and Milton Keynes scale. Within the paper, we've described how that Integrated Care Partnership, how we're proposing it should work. And these proposals have been developed with input from all 4 local authorities, including Luton and the designate chair of the Integrated Care Board. And we're proposing that the Integrated Care Partnership should be chaired by a local authority member, and the 4 local authorities are currently working on how that person will be appointed, that there should be a call meeting in public, and that then there will be workshops which will be more interactive events with wider colleagues invited on specific topics of how we can work together across the patch to tackle some of the really challenging issues for our population. You'll see in the paper there's a draft membership there for the Integrated Care Partnership, and for Luton Council there would be up to 3 members invited, so you would be able to appoint up to 3 members, one of them being the Health and Wellbeing Board Chair. And the Health and Wellbeing Board Chair would be part of an agenda setting group for the Integrated Care Partnership's work. We'd also have the Director of Public Health there and other colleagues from across Luton and Bedfordshire, Luton and Milton Keynes within that partnership. So that's a new way of working that's coming in through the Health and Care Act that we will all be part of, including the local authority. The second change coming through the legislation is the creation of a new statutory body, a new statutory NHS body called the Integrated Care Board. It will take on the functions of the Blmk CCG, and it will also have some additional functions that are being allocated to integrated care boards to help them achieve their objectives in terms of improving outcomes, reducing inequalities, enhancing value for money, and supporting broader social economic development across the Bedfordshire, Luton and Milton Keynes patch. Partners, including this local authority, have all been part of discussions about the membership of that integrated care board. Some of it is required by statute, and there's again local discretion. A particular area for local input has been around partner members of the Integrated Care Board, and Luton Council will have one member on the Integrated Care Board. That will be the Chief Executive or a nominated director, as local authority members, councillors, are disqualified from being members of this particular board through the draft legislation and through statute. In a similar way, they're not able to be members of CCGs. I'll hand over to Nikki to talk about the place-based partnerships and the PCNs, particularly with the Luton element of that. And then the last part of the paper talks about provider collaboratives. And I've seen David's here. He might actually want to talk about the Bedfordshire Care Alliance at that point. So happy to take any questions, Chair, once my colleagues have finished.
Thank you, Maria. So I'll just pick up on the place-based partnerships, and looking around the table, there's a number of people that are part of it. But it's very much that new arrangement of that we call subsidiarity, which is basically working at a place level, and particularly if we, as we're talking about Luton, we absolutely know that we've got a very bespoke population that we have to work really carefully with. And I'm just thinking of the work we're currently doing with Sally, Director of Public Health, with our vaccination cover. So we absolutely got 19 wards, and we know massive variation. So that place-based partnership really gets us to look at that household level, in neighbourhoods, at ward level. So the place-based board, we had a meeting this Tuesday, and where we've got to for that, for example, is identifying our priorities that are very much led by the Health and Wellbeing Board's health and wellbeing strategy. And that is very inclusive. It's not just about statutory partners, it's actually about the community. So community voluntary sector, a really large part, and we also are fortunate to have very active Health Watch. In the place boards, you see this terminology, primary care networks, and this is where we've got the 26 practices working across 5 primary care networks, and they are networks. It's really important. They're not organisations, they're networks of populations, and that's how it works. And that's how those primary care networks are working with the care sector, the community mental health sector, and of course the interface with acute, and that is very much about the discharge, but also preventing avoidable admissions. So that's just about the primary care networks, and I think it's really super to actually hand over to David to just give an example of what we're talking about, the provider collaboratives, and in particular Bedfordshire Care Alliance.
Thanks, Nikki. The Bedfordshire Care Alliance really consists of 2 different things. One is actually a partnership of all of the organisations which form part of Bedfordshire, and that's important because much of our health services are organised on a Bedfordshire-wide basis. And for example, the organisation that I represent covers all 3 boroughs, and the organisation that that the services provided by ELFT, again, similarly cover the whole of Bedfordshire. So when we come to change and transform services in the health service, actually coming together as a partnership across Bedfordshire is really important. So that's the first thing. The second thing which accompanies that is actually the providers within that, and that's really ourselves, ELFT and Cambridge Community Services, as the 3 key NHS providers coming together and trying to work together to try and make those services across Bedfordshire more coordinated. So it's really important for us that Luton Borough Council is part of that partnership, and whilst clearly much of its work is at place level, when it comes together with this partnership, it allows it to influence the way that health services work across the whole of Bedfordshire. So that's in summary what we're trying to achieve. And I think in the past, that's been a little bit more difficult. It was a little bit more difficult because we had two CCGs across Bedfordshire. We had Luton CCG and we had Bedfordshire CCG. Now that effectively that commissioning is under one roof, makes it much easier to make the services more coordinated within the geography of Bedfordshire. Thank you.
So I think Maria, David, myself, it will happily take any questions.
Thank you. Any questions? David.
Thank you, Chair, and thank you. And I think for me, it's difficult to know where we are when it comes to STP or ICS. Every time we come here, there's something new, and it's difficult to keep pace with the changes that's going on. I don't know whether we are now you're called STP or it's back to ICS. All I hear is the CCG being abolished, which we all know. Okay, so my question then is, in terms of ICS, you talk about two bodies, partnership and a board. In terms of the partnership, you talked about having the health and well-being board chair as one of those three. Are you asking the scrutiny to provide delegate or member? Are you inviting us to be part of? Because the reason I ask this is, in terms of governance, we used to have the JHOSC. I don't know what's going to happen to the JHOSC that we used to have. And we had members from this group sitting in terms of scrutiny. So that's question number one. Did I hear you right saying that on the board, councillors have been barred, therefore councillors can't be there? If that's the case, so if the CCG that we used to sit on, part of JHOSC, that was scrutinizing, that means none of us can be on the board. Therefore, the only place we have now is the partnership group. So we used to have 3 people from this group on the group, the JHOSC. So I'm not sure how scrutiny is going to be done. So if somebody can explain that to me. And then coming back to place-based partnership, you talk about the subsidiarity. I don't know what's going to come out of that. But as you know, we were politically disengaged from STP because of the way decisions were being made in terms of Luton. So where are we with all those, I'm not going to call it shenanigans, with how we integrate with all these bodies? What's going to happen? I need to know. I'm not clear in my mind where we sit as scrutiny. So if somebody can take those in turn, go from the partnership, invited or not, then to the board, disbarred, JHOSC, where do we sit? And calm down. Thank you, Chair.
Maria, do you want to go first? Yep, perfect.
Okay, thank you. Thank you for that question, Councillor. And I agree, it isn't helpful, the terminology, all the abbreviations and the way it keeps changing. But yes, Integrated Care System, ICS, is now the term rather than STP. The ICSs have evolved from the STPs. Your questions around the Integrated Care Partnership and scrutiny members being on the Integrated Care Partnership, it will be up for Luton Council through your decision-making processes to decide which members you wish to put forward as members of that Integrated Care Partnership. It's a joint committee between Luton Council, the other 3 councils in BLMK and the Integrated Care Board, and each of the partners will need to decide for itself who it wants to put forward into being the members of that joint committee. So there's nothing saying in the terms of reference whether that includes scrutiny members or not. That's a decision for the local authority to make. Your next very good question about the JHOS, the joint scrutiny arrangements across BLMK, that hasn't been operating for some time. I'm not quite sure why it isn't meeting anymore, but it was meeting in the early days of the SDP. It still exists as a construct that can be called together. And again, I think that's something for the local authorities to consider, whether when we're in these new arrangements, having meetings of that joint scrutiny committee would be helpful. And certainly, I think as an integrated care board perspective, we would be happy to be part of those arrangements if there are things that the 4 scrutiny committees in BLMK want to discuss collectively, which is what that forum was for. So again, that's a possibility. That's something for the local authorities to discuss and consider. And in terms of your point about the integrated care board and councillor membership of that, as I said, that is in the legislation that councillors, elected members, are disqualified from being a member of the Integrated Care Board. That is the same position as for clinical commissioning groups. So that's the position. So the local authority will be able to nominate an executive, an officer, to be a member of that board. And that would be the chief executive or a director from Luton Council rather than an elected member. So elected members have the opportunity to be members of the Integrated Care Partnership, which is shaping the strategy. The Integrated Care Board's role is to deliver the health plan, to deliver the strategy that is set by the partnership, which has elected members' voices on it. So I hope that helps.
So shall I just come in with your third point, Councillor Aggleby, is about the place boards. And I think we've mentioned this previously, is that what makes a difference to the lives of the residents in Luton will be the wider determinants of health that don't impact the health service. So education, housing, the place, the environment you're living and all the rest of it. So that is the really important thing. So if you look through the guidance through the ICS and through the establishment of the integrated care partnerships and through the integrated care board, it is trying to put autonomy that at a place level. And at the moment, and I know Carolyn and Robin, we've had conversations, this is not taking any of your power base from the council. It is where it makes sense to collaborate. And I think that point that Maria illustrated a moment ago about the joint health overview and scrutiny committee, that is in the gift and the authority of the local authorities. If there are elements that you want to collaboratively work on, we can, you can call upon that forum. But I think one of the reasons it stopped was each of the local authorities felt quite, I think they felt quite passionate. They wanted their own health overview scrutiny committees to have their own meetings. So for me, that principle of and probably Carolyn or Sally may have a view, because certainly Sally is the Director of Public Health and Carolyn is the exec lead that I work with, is that it's your local communities and it's how we work in that genuinely collaborative way. And I know people say, oh, we talk about it all the time, but only this week, for example, we've done some work with Age UK Luton, which is absolutely about, we know loneliness, isolation, lack of befriending often means people can't get out of hospital, or more often that it may be the tipping point of somebody being admitted and going to the A&E department. So what we know is that by putting more resource in the community, that we will improve the well-being and ultimately the health and care of people. I don't know if that helps.
Okay, okay. So for me, just to be clear in my mind, Luton as a council can nominate 3 people. You've said that Health and Wellbeing Board Chair is included. That means we've got an executive on the board. So then the question comes to, where do backbenchers or scrutiny like us, who makes the decision as to whether scrutiny is part I'm still not clear as to who does that, because like I said before, we had 3 people. Since we are not on the board now, that leaves a big gap as to how things are scrutinized. The reason why I ask this is the public wants, you talked about this being a public meeting, but in terms of public, we want to know, is a meeting that is held in public, or is this a public meeting? I wasn't clear as to what you said. Is it a public meeting or a meeting that is held, a secret meeting that we are going to publish minutes, agenda for the public to see and all that? And are we going to be part in terms of what you publish, minutes and stuff like that? Still not clear. If you can explain to me, that would be very helpful, especially the process that we get involved, and then whether it's a public meeting or a meeting held in public, and accountability.
Councillor Appleby, if I just go back, at the moment, still working its way through government. So all of this documentation is yet to be, I think it's at the Health Select Committee stage, but absolutely the principle of openness, transparent, 100%. And I'm looking at Maria. There is no suggestion that the local scrutiny committees power-based changes. If there's any change to your local residents, we have to go through exactly the same process as we always have done. Consult with yourselves, and so it's getting that relationship really open and your role of interrogating and making sure absolutely continues. And Maria, if I'm wrong, you can correct me.
No, that's right. It doesn't impact the role and the statutory role of scrutiny. In the paper, paragraph 2.8, in relation to the integrated care partnership, which I think is the question Councillor was asking, the meeting will be held in public, a meeting held in public. So agendas will be published, papers will be published, minutes will be published. So they'll be open for the public to see and scrutinise, and for scrutiny committees to see and scrutinise. That's the core part of the meeting. So any decisions taken by the partnership will be under that meeting held in public banner. What we've said in the paper is that to help engage wider community groups and interested parties, we will hold workshops on topics as part of our development work as an integrated care partnership. So those won't be meetings held in public, because there'll be different kind of events where we'll be in a workshop format, but decisions won't be made at those workshops. That will be information sharing, building ideas together, and then any decisions that need to be taken will go to the meeting held in public, as described earlier. So I hope that helps. The Integrated Care Board is also subject to the Public Bodies Admission to Meetings Act, which means it will also need to meet in public in the same way that CCGs do, publishing agendas, minutes, papers, etc.
Chair, again, public meeting doesn't mean meeting held in public is not the same as a public meeting. So if there is a member of the public sitting in the gallery and they want to ask questions, because it's not a public meeting, they can be barred. They will be told, no, you can't participate. That's what this means. In reality, that means the public will just sit there and have no power to question those who are making decisions on their behalf. That is why it's important that we, the elected representatives of the public, are sitting there to ask those questions. And I think through you, Chair, we need to have an urgent meeting with the council to make sure that people from this committee sits on there on behalf of the public. As you know, one of our aims is, if there's a significant change, we are supposed to scrutinize. Decisions are going to be made here. Public can't say a word. The only people they have now is us doing something about it. Executives sitting there, they've got a place. Who, through public residents, is going to hold people to account? So, Chair, I think we need to have that meeting urgently with the council to make sure that we have a seat on the partnership, to make sure that the voice of the public is heard. Thank you.
Thank you, David. Yes, I agree. I think obviously as a group we need to make sure that the scrutiny process continues with this organisation, and we certainly need to find out what the process is for choosing those other two members of the group are.
Chair, if I may advise, nothing changes as far as scrutiny is concerned. The JHOS still is in existence, although dormant on the shelf at the moment. And in theory, we have 3 members elected to it. Generally speaking, if you're a scrutineer, you can't be on the board as well, because your role will be to scrutinise the decision being made. So you can't actually take part, generally speaking, in any of the governance structure of the new ICS. So whatever's going on at the moment, scrutiny will carry on, and us as officers will be advising you in due course when everything kicks off again, so that if there are any major changes in services, then the JHOS, if it cuts across all the BLMK area, will come into effect. If it's Luton only, Luton place-based, then obviously this committee will actually be involved. So nothing changes as far as scrutiny is concerned, but you can't be on the board if you're going to scrutinise. Thank you, Chair.
So are we saying that the membership of the JHOS carries through to the ICP, or?
It's up to the council to decide on this one, like it was already been said. And like I said, at the moment, we already have members elected to this BLMK JHOS, which hasn't been sitting. We've never lost our seats on there, despite the fact Luton was inactive for a while because of the reason Councillor Hagley mentioned. But we've still got these 3 representatives appointed to the JHOS. So we can have a greater discussion or wider discussion outside the meeting. Chair.
Okay, but the point that Councillor Hagley is making is that so one of those people is the Health and Wellbeing Chair, and we don't know at the moment who are the process of deciding who the other two members are. So we should be able to know what that process is. Okay, so.
As you rightly said, to be honest, in terms of statutory board, that's fine if we're not going to be there, I do understand. But in terms of the partnership, I think that is where now we have opportunity to make sure that resident voice are heard. And that is all I'm placing the emphasis on, not the statutory board. What I'm concerned about in terms of the JHOS, as you know, we disengaged, and therefore we didn't know what was going on. And that hasn't met for so long. There's an issue about public voice, and I think that is what I'm talking about. We need to make sure that the public or residents have a voice in terms of the partnership, and that is a concern.
Let's follow this up outside of this meeting. Thank you. Jeff, did you have a question?
Yeah, mine is really 2 parts. First of all, can I ask, do these changes excite you, or do they make you apprehensive? And how robust will the IT systems be to make all this work as an integrated package, which is what it's called? Nikki.
If I genuinely start, is that as you know, I am a nurse. I still remain on the register, and for many years we have said that we need collaboration. So we need health and care. So genuinely in this arena, I think Luton have been ahead of the game in the sense of working collegiately and collaboratively. So the direction of travel is absolutely and genuinely, I would say it does excite. And it genuinely does excite me, because over certainly the last 6 months, we have been genuinely talking about the well-being and the outcomes and addressing the inequalities, of which there are many in Luton. So, and I know that Carolyn's only been with us since September, but I have really felt enthused. So yes, excited is how I would say. With the robust of the IT, I think, and in fact, David, you're probably better to talk through, because David's been chairing some IT very strategic discussions exactly about how we get that continuity of records, because as healthcare professionals and the wider system, you're only as good as the last bit of information. So David, I think it'd be quite useful for you to explain your work.
Yeah, thanks, Nikki. Yes, I mean, I'm absolutely excited by some of the opportunities that this brings, because as Nikki referred to, what we're really trying to do is to get that integration. And what I mean by integration is that we start, certainly from a health service perspective, start being much more proactive in what we do rather than reactive. Most of what we do in my hospitals is reactive care. People get ill and then we do our best to treat them. But in fact, much of what we're trying to achieve through this system work is to be much more proactive. Now, the problem we face at the moment is that certainly lots of the individual institutions, whether that's the council or whether that's the community trust or whether that's the acute trust or whether that's a GP, can only in the main see the part of the care that they provide, so what they do. And if we're going to become much more proactive and understand what to see that patient or that resident in a holistic way, to see what's really happening with them. And many of these individuals not only have a GP but might be on several different waiting lists in the hospital, might be an emergency admission in the hospital, might be under the community mental health team, might well be receiving a care package from the council. At the moment, you can't see that full picture, and so the purpose of us trying to develop an IT solution is that we can see that full solution and therefore make decisions about people in a different way. You know, the classic situation, of course, is when patients come into A&E and we don't really understand the full social context of that patient, or indeed what they were like yesterday. So is this a genuine emergency, or is this a patient who actually is already, for example, end of life, and actually we don't want to be doing the full gamut of tests and start a patient on a whole new set of interventions when actually there's already a plan about their care. So for me, that what I do is I chair a group across Bedfordshire, which brings all of the partners together, and our role, and we're really making great progress in this, is developing that IT solution, which means that we will be able to see the full picture of our residents and our patients. And once that happens, we'll be in a much better place to provide the sort of proactive, rather than just responding when things go wrong. We'll be starting to be able to really change the way that we provide care in Bedfordshire.
Thank you, David. So from what you're saying then, you are pretty confident the way the IT systems are going to support all this structure.
Well, it's not easy, because all of the partners have different IT systems. And not only that, there are challenges about, particularly between health and social services, about making sure we've got the same person, because actually we use the NHS number in different ways of identifying people, and we have to make sure we're actually talking about the same person. So there are all sorts of technical challenges and information governance challenges. But what we're not proposing to do is put a new IT system and get rid of everybody. What we're trying to do is everyone keep their existing IT systems, and we put in place and overlay that sort of front end, which allows us to access all of the individual parts. So when a professional or a clinician in the system looks to that, they see effectively something that sucks information from all of the individual partners and gives us that picture of the patient. And it's all doable. The IT is there and can be done, but it does require, and this is where the whole partnership comes in, it requires those partners to work together to achieve that, and to all commit to making that happen. And that is what's happening at the moment. We've got that commitment happening. It's been very significantly helped by the central funding that's come in. So the funding is there. We've not asked for funding at this stage from councils or the NHS because the money's come in centrally, and we're using that money to build this at the moment. And it's really having, and it really will have a massive impact.
Sorry, we can't hear you now on the.
Someone just said that they can't.
We can now.
Okay, thank you.
We can hear you now.
Right. So if you missed that, thanks, Nikki, Maria, and David for that report. Thank you. Yes. Yeah. We look forward to an update in due course. Moving on to item 7, update on COVID-19 in Luton. Sally?
Yes, thank you. So the paper is in your packs, which was just circulated yesterday, so is very up to date. So I'll just talk through where we are in the updates since the last meeting, which feels like a lifetime ago, so that the whole world around COVID has changed since then. So our case rate is currently 1,800 per 100,000, which is the highest it's ever been. It's really quite a high case rate. And it's similar to the East of England and England average. We've seen hugely sharp increases over the last month across Luton and Blmk, East region. So the figure 1 in the paper shows that really steep increase. It does look like it's slowing and plateauing now, though, on the latest data. Not this little dip that you see in the graph here, because that's more of a data lag. But actually, if you look at the data that's coming through, it does look like that increase is slowing. We are aware, though, for other peaks during the course of the pandemic, Luton has had what's been known as enduring case rates. So we tend to have been slower to reach the peaks that other places have seen and then stayed there for longer. So there is an awareness that may well be the case this time around as well, but we just need to wait and see on that. But we have reached that high rate seen at East of England and England averages later than some of our neighbouring boroughs. So it is looking like that may well be the case again this time. The good news, though, is that we are not seeing the increase in death rate and hospital admissions that we've seen in other periods of the pandemic. So figure 3 in the packs shows that compared to the last 2 peaks, where we did see a substantial increase in deaths above the 3-year average for the time period, substantially above that rate, we aren't seeing that at all at the moment, which is really good news. And equally, on figure 4 in the packs, I think it's a really telling graph, which shows that at the moment we're seeing a very much higher. We're seeing a very much higher background case rate, which is substantially higher than it was in the last winter peak. So the blue line is much higher than it was last winter, but the hospital admissions continue to be lower. So the proportion, although hospital admissions have risen, the proportion compared to the background case rate is much lower. So we're not seeing that proportionate increase, which is good news. Obviously, we now have Omicron, and that is accounting for the majority of our cases now in Luton. But we are seeing that the booster vaccine provides good protection against symptomatic illness and hospital admissions with the variant. So that good news story around the hospital is both because of Omicron seeming to be much more transmissible, but less causing less illness, and also the protective vaccination in the background population, particularly the booster, which is good news. There is still a lot of transmission, though, so the booster and the vaccine isn't protective against the
transmission, but it is definitely showing to be against hospitalisation, which is good news. As you know, there's been a lot of changes to guidance. So the isolation for positive cases on writing this can now end after 7 days. But obviously, there's been an announcement today that if you have 2 negative LFDs, then isolation can end after the end of the 5th day as of Monday. So that's changing yet again. We were just saying that we could amend our flowchart and because we didn't think it was going to change again anytime soon, and it has just changed again. So we just need to do a quick review of the flowchart yet again on that. And obviously confirmatory PCR is no longer needed for asymptomatic positive LFDs. The other main thing to update on is the testing in the community. So we're still doing a lot of options around community testing, and LFDs are available to be being given out in the mall. There has been some issues you'll have seen probably on the news around supply chain issues on that and availability of tests, but we have just received another delivery, so our stocks are fine in Luton at the moment. The vaccination programme continues to roll out, and we're doing lots of work, as Nikki mentioned previously, on the vaccination programme, and really working hard to enable vaccination to be available to people in Luton. We are lagging behind where we would want to be in terms of uptake, as we have been throughout. We are seeing, still continuing to see a large amount of hesitancy on the vaccination programme for the Luton population. So we're working hard to make sure that vaccines are available, convenient for people to access. So we have various schemes like the taxi scheme that we've had throughout that we're still continuing to promote. And we are in the process of developing a really robust 3-month inequalities plan where we're looking at those areas that have the lower uptake, the particular wards that have lower uptake, and looking at how to ensure that those wards have enhanced access and increased communications about the vaccination programme, particularly available in those wards. We're looking at reopening. We had a pop-up before Christmas in the old post office building in the mall, and we're looking at reopening that as a more of a stable offer for that 3-month period. So hopefully, all being well, that will open up next week. There's some tables in the paper, which is some new data to show, which shows by ward how we're doing in terms of uptake of dose 1 and dose 2 and dose 3. And you can see that there's a substantial number of sort of missing dose 3s for people that have had the second dose but not gone forward for dose 3. So there is a lot of work still to be done. And you'll see in figure 7 that Luton, when you compare to nearest neighbours, that population is similar. We are unfortunately down the bottom in terms of uptake of the vaccine. And when you look at the stats around our uptake compared to the rest of the boroughs in England, we are the 9th lowest for the booster and 19th for dose 2, 19th lowest for dose 2. So there really is a lot of unvaccinated compared to other boroughs in Luton, and we're doing all we can to make sure that we can get as many people as we can vaccinated. I will stop there, I think, and open up to any questions. Oh, sorry, just one last thing just to mention. We've just been successful in obtaining an extra funding for what's called COVID Vaccination Champions Program from national government. So we're working quickly on plans to mobilise that, which is around vaccine inequalities and working particularly with groups that have lower uptake. So we'll be looking at developing a vaccination champions programme and network of voluntary sector organisations to help support that work. Thank you.
Thank you, Sally. Any questions? Steve?
Right, with all the policy changes, it's difficult to keep up with some of the things. Obviously, I've seen a lot of stuff about what it means to the general public. I'm just wondering, Plan B as it is now, in terms of care homes and assisted living facilities and stuff like that, has that meant that there's been closures to any kind of shared social space for those in care homes and assisted living facilities?
So care homes and assisted living, but particularly care homes, continue to work with a lot of COVID guidance and have been managing in terms of infection control in a much more robust way than prior to the pandemic. There's a lot of guidance for care homes that they're working through, and if there is cases, so they do regular testing in care homes as a routine. So they have a program of routine testing, and when there's outbreaks, then they do absolutely close communal areas and do care by cohorting and all of those procedures. So there is a really robust procedure for management of cases and outbreaks in care homes now.
But as far as you're aware, there's no like national guideline that kind of any social spaces closed as a general rule.
I'm in the first and second waves. They were all closing communal areas. There was a lot of work around that. I am not sure if that is still the case. I don't think it is unless they're in an outbreak, but I'll need to go away and check that. I was working in last year. I was the lead for the care homes work, so I was much closer to it. And I've got somebody else in my team that does all of the liaison with care homes now. So I'm not as up to speed on the detail of the guidance on care homes now, but I think unless they're in an outbreak, they will have communal areas open again, but I can double check that.
I'd be grateful if you could, if you're able to send that in an email at some point.
Yeah,
that's absolutely great. Thanks.
David.
Thank you, Chair. Thank you, Sally. I know you're doing everything possible as Luton to make sure that uptake levels are high, but I don't think, as you just said, it's very low comparatively. Reasons behind that, I think we need to find out why people, is there fatigue in terms of vaccination fatigue? I think it's important that we do still try and make sure that the uptake levels are high. I'm not sure what the effect on test and trace, is that still happening? Because you talked about having to secure funds for champions. How about test and trace? Is it still, are we on top? I remember months back, we were hailed as the best in town. Are we still on top? That's question number one. And the effects of this in hospitals. So I think that's where my question will go to David Carter from L&D. I mean, recently we did hear that you've stopped visitation to the hospital. I'm not sure how far we are with that, but that visitors were not allowed, or only one person allowed in terms of visiting the hospitals because of Omicron. How many admissions do we have in the hospital in terms of people who are in the hospital? The increase since Omicron came. In terms of ventilations, how many people are on ventilator in the hospitals? And if you know if the gender in terms, as previously they said men were affected and BAEM groups, is it still the same? Do we know? Now there's staff absence levels. As you know, this Omicron is very infectious in its nature than Delta, and apparently there's a lot of staff has been affected by this. So can we know how you're coping in terms of staffing levels? What percentage of your staff are off sick because of Omicron, and how we are dealing with this? And then another issue that has come up is transmission in hospitals, hospital-acquired infection. Apparently, most of the patients coming to hospitals may not come with COVID-related issues, but when they get into the hospital, then they are infected with COVID. So if you can update us the situation in L&D, that would be really helpful. Thank you.
Thanks. I'm happy to do that. So we currently have about 105 patients in the L&D at the moment who who have COVID. That is probably the highest number in East England at the moment, but the numbers do go up and down. And certainly we've seen significant increase in those numbers since Omicron became the dominant variant. It's fair to say that we're probably in a slightly better position in some ways than we thought we might be at this point, given some of the modelling. So, and I think we feel that at this point we are at a position which has plateaued. So in terms of new admissions, as Sally has been reporting, we feel that we're now at the peak. That's been very difficult to cope with indeed, particularly in terms of the way that we need to isolate our patients as they come in. And you referred there to the transmission in hospitals. So we are seeing increased levels of transmission within hospital. Fortunately, as we know that this variant does not appear to be as harmful as previous variants, but its transmissibility means we are seeing more numbers, both in terms of what is coming in through the front door, but also the transmissibility. Particularly, as we know at the L&D, we've got some relatively old and poor estate, and a relatively low number of side rooms. So many of our wards clearly are more prone than in other places, and that's partly why we're trying to rebuild parts of the L&D. It's been very difficult over recent weeks, and in terms of staffing, we have approximately 800 staff off work at the moment, and about half of those are related to COVID. So normally our absence rates are 3 to 4%. They're currently 6 to 7%. So it's had that type of impact. So that's incredibly difficult. The good news is that appears to be coming down at the moment. So the numbers of staff new staff that have gone off in recent days has slightly reduced. We haven't. We are at the limits of our critical care capacity, but we've not had to. We're still coping in terms of the number of patients that are needing the critical care facilities. And again, that's a change in respect to previous waves when the number of patients in critical care as a proportion of the admissions was higher. So that is again evidence that this variant is less harmful than other variants. However, we still do have patients that are, and including some young patients in critical care, that show just how damaging this disease can be for those patients. But clearly, there are both patients who are vaccinated and patients who are unvaccinated in hospital at the moment. So vaccination does not ensure that you won't come to more severe harm, but certainly the numbers of the probability is clearly reducing. I don't have the breakdown of our numbers between female and male or age, and Sally may be able to provide that, or we can provide it for a future meeting. So I think in summary, we've had a very, very difficult few weeks indeed. We have got preparations in place in case there is now a further surge. So that would involve putting additional beds in what are currently not occupied clinical areas. At the moment, it doesn't look like that we'll need to use them, but we have got those plans in preparation. And at the moment, it does look like our position has plateaued, both in terms of admissions, but also in terms of number of staff that are off sick at the moment. I'm happy to take any further questions if that helps.
Thank you, David, for the update. But in terms of the profile of patients, I want to see the data so that we know in terms of vaccinated and unvaccinated, because there's that debate whether when you're vaccinated, what is the effect being end up in hospital. I think, as we know, the uptake levels are not as expected in Luton. This will go to show people whether when you're vaccinated, the benefits. So I think by working together, people see the benefits of being vaccinated. If that's clearly shown in hospital, maybe that will change minds. So I think those figures are really important. In terms of staffing levels, as you know, there's legislation that we should be getting rid of staff by 1st of April if they are not fully jabbed. So in terms of looking forward, if we are not able to deploy these staff, what percentage of your staff are going to be dismissed or potentially going to be dismissed if you're not going to find alternative employment for them? Because if currently we are struggling with staffing levels and we're going to be dismissing by April 1st, I think we are in deep trouble. So if you can expand on that, that would be very helpful.
Yeah, just on that point. So we are currently looking at all of the members of staff who would appear to be unvaccinated at this point. So our vaccination rates were about 90% of our staff. However, the picture now that we're looking through it individual by individual is more complicated than that, in the sense that trying to identify those staff. For example, we've had staff who may have been vaccinated overseas that have come to work for us. Recently, there are staff who are just pre-retirement that are not planning to have the vaccine but would have departed anyway, and some staff who are leavers, and some staff that we may have been vaccinated in other places and haven't, and the national databases aren't quite updated yet. So there's quite a complex picture that we're trying to work our way through. So the answer is we do not yet know how many staff would be in that position, and there are a number of staff. In fact, I was speaking to some staff yesterday who are undecided. So there's some staff who've not yet made that decision about whether they will be vaccinated or will not be vaccinated. So at this stage, I do not know, and I hope to know in the coming weeks to make a much more firm estimate of the number of staff that we would actually need to dismiss if they couldn't be redeployed. And the reality is that we would have very limited ability to redeploy the staff into other roles. So I hope that it will be very small numbers, but at this stage I don't know. I think it could be significant in terms of some of those staff may well be in what we might call critical roles, where if they were, for example, part of a rota, and we're doing everything we can to try and minimise that number. I think it will be. I mean, we're an organisation which employs now 9,000 staff. I think it's likely to be in relatively small numbers in terms of. We're hoping to keep that into small hundreds, but still that could still be significant in terms of the overall effect. I'll hope to know more in a couple of weeks' time, but I am worried about the potential impact, even if it's relatively small numbers of staff. And also I'm worried because of the effect on our staffing morale and the way people feel about it. There's very strong views about some of the staff, and a number of staff I've spoken to said they've become more entrenched in their position not to be vaccinated because it's mandatory. Actually, they would have got it, and they feel such a strong principle. However, on the other side of the argument, we understand why the government has decided to do this in order to protect everyone. But at the sharp end, we're trying to do everything we can, and our time is running out because those staff need to be vaccinated by early February for their first vaccination, if they're to get the second vaccination by the end of March. So we've only literally got weeks now to get to the point at which we will know. The final point just to mention is that we are due to receive the information from the NHS centrally tomorrow around the way in which we might go about dealing with those staff who remain unvaccinated on the 31st of March.
In terms of public visiting the hospitals, has the leave been taken about how many people can visit the hospital? What's the status now?
Yes, no, we've moved back to a situation where we're restricting visiting to the hospital to being where we were before in terms of the restrictions. We would hope to lift them as soon as possible, I think. But clearly at the moment that it's incumbent on us to reduce the traffic on the hospital site as much as we can, and therefore we've had to move back from the situation where we were allowing visitors on site. We clearly obviously do and always maintained right through the pandemic the ability for families to visit those patients who might be nearing the end of life, but we have restricted our visiting policy. So we do not allow visitors on site at this point.
in terms of the question that Jeff asked before, I've never seen any IT project in NHS that has been successful. So I just wish you all the best and all the luck in the world. Thank you.
Thank you. Thank you.
Thank you, David. Is there any more questions? Okay. I just have one comment, and it's just to thank everyone for the hard work they put in response to the emergence of Omicron and the ramping up of the vaccination program in response to that over and during the holiday period. So thank you for that. And thank you for your report, Sally. Thanks. Okay, let's move on to item 8, the JSNA report.
That's me again.
Okay, thanks, Sally. Yep.
So this is really to update the committee on the process around the JSNA. So JSNA is the Joint Strategic Needs Assessment. So just to remind people that this is a statutory requirement at place to understand population need, to inform commissioning and services to ensure that they're meeting the needs of the population and to give an understanding of population at a local level. We are a bit behind on a refresh of our JSNA due to COVID and resources and various reasons. But we're well on the way to getting back up to date on it again. And so this just outlines our timeline and plans around the JSNA. And also within that, a pharmaceutical needs assessment, which is also a statutory requirement, and we're due our refresh now. It's every 3 years, and ours is going to become out of date in April. So we're well on the way to getting up to speed on that one as well. So the idea behind the JSNA now is that instead of, as previously, it's been a huge document that more or less as soon as it's written, it's starting to become out of date. The idea is that we will have a suite of documents, a suite of products that will be hosted on our Luton Information Observatory website. So the first one will be a single kind of overview of Luton and the Luton demographics and population and socioeconomic status. So we call it This is Luton, and it will hold a lot of demography data and information about the population within Luton and the high level population needs within Luton. The other, alongside that, there will be a similar high level document around health and care needs in the population in Luton, which will sit alongside it and will be updated annually or more frequently for part of it if needs be, if the data if the data is such that it needs more regular updating within parts of that document. And then alongside those, on an annual basis, we'll do sort of deep dives and in-depth needs assessments on specific topics. And there will be a steering group that will review which topics need those deep, in-depth reviews on. So at the moment, we're taking forward one on sexual health because we are due to recommission our sexual health services next year. So we need to really understand what the service is delivering, what the population needs are, where the specific priority areas within that service. So in order to commission an effective and appropriate service, we need to really understand that. So that gives a reason for a deep dive in that area for this coming year. And we're also working across the ICS on one on musculoskeletal illnesses. So those are the two that we're taking forward at the moment. But the JSNA steering group will have a robust process for reviewing which ones we need an in-depth review on an annual basis. And we'll have a better process for archiving out-of-date reports and working through to make sure the data on the observatory website is up to date. There's also a programme of work across the ICS called Population Health Management, which is about using data and linked data sets to identify at-risk cohorts and then targeting interventions for those cohorts. So you might look at people that have a particular illness and mental health and are deprived, for example, or from a deprived area, and getting a subset of a cohort so that then you can target interventions specifically on particular groups. So it's a data kind of approach. and you link NHS and social care data, for example. So there's a whole work stream about that across the ICS, and we're also looking at what specific projects around that we would want to do in Luton, particularly working with primary care. So there's a lot of work happening around that sits alongside the JSNA, and it's interrelated. We're also at early stages of developing the idea around what we're calling a public health observatory. So across, you're probably all aware that across BLMK ICS footprint, Bedfordshire and Milton Keynes already have some shared public health functions and a shared director of public health and a shared health intelligence team. So when they create products for their particular boroughs at place, they will be aligned because they've got a shared intelligence function, and it makes sense to work in that way, so that for in primary care there's a recognised way in which profiles look, or across the ICS there's a recognised way in which we're looking at our data and can compare and contrast across, and there's economies of scale in doing it that way and shared learning from different teams. So we're looking at how we can work better in that way, whether it's just kind of working more closely together, or whether there's actually some kind of way of inputting a shared resource, or having a shared senior manager that oversees that across the whole footprint for the ICS in terms of that public health intelligence. Or, you know, there's lots of ways in which you could think about doing something like that. So there's early stage discussions about that being worked up as well, and with an options paper being developed. So I will stop there. It was just really to update people that's the direction of travel at the moment. And as we develop the JSNA further, I can bring back further updates in terms of the actual products and documents that we are producing as part of that. Thank you.
Thank you, Sally. Is there any questions? David.
Thank you, Sally. I think this paper really goes to show why we need to keep an eye on ICS. I mean, for me, I think on page 20 and item number 8, that talks about the footprints, where it says 3 of the 4 local authorities, we are the only ones missing. And that, I think, is really important, that we do have a seat on the table when decisions are made. Your document talks about an option paper that is currently being developed and will be presented to the Health and Wellbeing Board. Are we going to scrutinize this paper before it goes to Health and Wellbeing Board? I think sometimes we tend to forget that we are supposed to have the scrutinize things before it goes there. So is this paper going to come to us first, or how is that going to work out for us? How are we going to be part to scrutinize before it becomes whatever policy it may be?
It can certainly come here as well, or before. So that sorry, I've just got the wrong paper in front of me. I was reading about COVID again. So this is about it's not about not being around the table for decisions from Luton. It's about how we analyse data collectively as a footprint. So Luton not doing all of its own way of analysing things, or way of presenting profiles. So there's a consistency and a shared learning across the 4 around data and analysis, and economies of scale around that. So there are win-wins and different ways in which we could do it. So it's not about setting up services. It's about the support and enablers around the data and intelligence, and how we're using that and how we're sharing that across the system. It makes sense to kind of think about that collectively and learn from each other and do things in a similar way. And we could also, if people are managing to link data sets in Milton Keynes, we can think about doing the same in Luton, and then people across the ICS know that one borough isn't behind the other in terms of how we're managing our data across NHS and social care and housing data. So it's about kind of levelling up and getting everybody up to speed and sharing learning and sharing approaches, so that there's a level playing field around the data and intelligence approaches. But the options are still about how best to do that are being looked at. So I can absolutely bring that options paper here.
Sally, for me, I think, yes, what you're doing is good so that we know what's going on. But again, we have at place and at scale. We are missing at scale. That's my concern. That's why I talked about the JHOSC. It's dead now, and we don't want to miss out. And what you're doing is good so that we can share practice or best practice and support. But I think, again, we need to make sure that Luton has a say and whatever is going on. So it'd be good to have the paper here, how scrutinize it and see how we can also support and how, if we have to contribute towards the scale. That's my worry, what's happening in scale, because whatever is happening around our neighbors definitely will affect us. If there's an emergency and we have to share resources, Luton is going to be affected. No two ways about that. That's why I worry that at scale, if you're not there, we will lose out. So thank you.
Yeah, okay.
Anyone else? Okay. Thank you, Sally. And just like to say on behalf of this group, congratulations on your promotion to Substantive Director of Public Health. Thank you.
Thank you very much.
Okay. Moving on to item 9, primary care GP access. Nikki.
Thank you, Chair. I'll just give you a 2-moment overview, hoping that you've had the opportunity to read it. Access to primary care is often a contentious issue, so it's just outlined in the paper. I think I said earlier, we have 26 member practices working across 5 primary care networks. We now have data, which I think is quite helpful. So in any month, there are 96,000 appointments. So I think it just gives you a bit of an illustration. We've got about 220,000 population registered with practices in Luton. So in any one month, and that's fairly average. So that was September, October and November. And just to do a little bit of myth busting, 70% of those were face-to-face. Now, clearly the guidance has changed yet again, and where we are encouraging member practices to do as much online and remote just because of this Omicron, so seems to be transmissible. So we've equally in the paper, Amanda Flower, who prepared this and is overseeing the primary care access programme, and it's really to emphasise that primary care is a 365-day service 24/7. And for us in Luton is we need to get that offer correct. So we don't want people rocking up to the A&E department. That is our aspiration. What we do have is we have what we call a control, you could argue, is that any member of the public who is able to walk in to the A&E department is triaged, and then they are, you could argue, channeled over to a GP primary care service. And that is where we work with the L&D, because what we don't want is people using that as their first port of contact. Otherwise, we may as well just open up a GP practice, at the L&D site. So it really is getting across that we are encouraging our residents to, one, register with GP practices, and we really make that easy now. There shouldn't be any barriers, but if any members of the council find anybody who's not easily able to access register with a GP, you can let me know. We've given those email address via Bert before. So assuming that people are registered, is that if they can ring the practice, we have we've put in the paper, there is support to practice for the telephony, because we do realise that if you ring and you don't know where you are, it's quite frustrating. But we equally know sometimes you can ring and you can be 23rd in the queue. So we do encourage patients to not all try and do it at 9 o'clock in the morning, because we get peaks and troughs. So for us in this access programme, you will see that we've got bespoke work to practices where we know that access isn't as good as others. So of the 26, we know that some don't offer such a good service as others, and that's where we're providing targeted support. And some of that is actually about the practices that do really well, supporting the practices that are struggling a little bit more. So we've talked in there about the GP community pharmacy consultation service. To unpick that jargon, what it is, and it's a national initiative, is if patients are presenting with a condition or a problem that can be managed by the community pharmacist, there is a smooth handover to the local pharmacist. But ideally, we'd much prefer our residents to access the pharmacist as their first port of call. But if they've, if they have gone to the GP practice, there is that facility, which is, as I say, it's a quick access to the pharmacy staff. I will just like to mention that our 111 service, I mean, the bank holiday weekend we had, it was almost double the number of people. I think we got to 1,200 people. That wasn't just Luton, that was across Bedfordshire actually. But the numbers accessing the 111 service was huge. Hence the answering the telephone within 1 minute was appalling. I think we went as low as 10%. However, when we actually look at the numbers and the time it took, it was about 1.5 minutes. So although they didn't make the target of 1 minute, but 1.5 minutes, I do appreciate is a long time when you're on the end of the phone and you're wanting urgent primary care access. So I think the thrust of this paper is there is, of all the practices, access. So it's just doing a little bit of that myth busting. As I said, 70% of it is face to face. We are I mentioned slightly earlier in this meeting about age concern Luton, that we've we've used some of our winter access money because again, we recognise that particularly the community nursing teams, and this is probably more to older residents, is that if we can get somebody to perhaps do some shopping or somebody to come in and actually be, a befriending service, that often does make a difference between people being able to manage to stay at home, particularly if the local GP or the nursing services are a little bit worried about them. And then finally, in fact, it wasn't in this paper, but it was some data I found earlier this week. We have got quite a lot of patients ringing the 111 service about repeat prescriptions. And we have checked in Luton, of the 26 practices, every practice turns it around within 24 hours of repeat prescriptions. So again, that is just you helping us to help the GP practice to give, good primary care access. So very happy, Chair, to take any questions.
Thank you. Any questions? Jeff?
Yeah. I visited the doctor with my wife a few weeks ago, and I asked the doctor about cancellations of appointments and non-shows. It still remains stubbornly high at 140 a month. Is there any work being done on that at all, Vicky?
You absolutely, so yes, and that is very the practice management. It's an internal to the practices. So if, for example, you wanted to cancel your appointment, we have to make it easy. If you can't get through to the practice, cancel it, then you're not going to. So we've made sure that the practice, it's easy for people to be, if they're, they're respectful. But for those patients that don't, I know that the GPs write to them once they've done it on 2 occasions. And again, if you have any ideas, because it's a waste of a resource to practices. So there, as I say, there's lots of initiatives. If you've got any other ideas, then we'd welcome them.
I would suggest taking a credit card number and charging them £10 every time they miss one. But it's not going to happen.
I know it is a very, very difficult situation, because I don't think people realise that it denies somebody else a booked appointment, and it may be the difference between, you know, somebody inappropriately going to the A&E department because you don't need an appointment to go there. So I agree. I think we just have to keep very much supporting the practices, because it's really, it's wearing on them. And we do know that it's some population. I'm just looking at Sally, is that perhaps when we're doing some of this targeted work, when we're looking at identifying people who perhaps haven't come forward for vaccinations, it may be the people who haven't come forward to screening. We need to do that wider message. So, making every contact count.
Thank you, Chair, and thank you. For me, I do agree with Jeff about in terms of did not attend, but I'm opposed to charging people for not attending. There's no way why we should be charging people for not attending appointments, because there are so many reasons why people do not turn up for appointments. I think what we need to do is mainly to educate people to understand the effects on GPs and the others if they are not going to attend appointment, how they need to cancel it first to make sure that that appointment is open to others. I say this because I have the app. Last time, I think last week, I was trying to book an appointment online. There was no appointments available at all. And for me, I don't think that's acceptable. The next, I think, 6 to 16 weeks, it said I wasn't going to have any face-to-face appointments. And if these people have hawked those appointments, it's detriment to me. So I think we need that education in terms of people to understand why they don't turn up and the cause and effect. My question mainly was to do with the Urgent Treatment Center. I think it was shut for staffing level reasons. Has that resumed? And do we know if there are contingencies so that this doesn't happen? That's number one. Number two, in terms of the paper you're talking about, I haven't seen it, but access to GP surgeries, I think, or to primary care is important. You said the target is 70. So does that mean the 30% people are not going to definitely not have appointments? I'm not sure what that means. So in terms of targets, isn't it supposed to be above 90? That's what the health secretary said, if I remember correctly. So if you are hitting 70, that means maybe Luton is being shortchanged. And if we can move target up to above 90, I think that will bring confidence to people. So I think that's what I have. We talked about 96,000 appointments, and what percentage of that is face-to-face? Did you split into face-to-face or online? Do we know? Have we moved to online appointments? And prior to the COVID situation, how many were face-to-face and how many have gone online? Thank you, Chair.
So if I answer your second question first, then I'll come back to your first one. So on the 13th of December, there was a national letter sent to all providers and to minimise face-to-face contact where it was clinically acceptable and clinically safe. So the figures I gave you, Councillor Aggleby, it's of the 96,000 appointments just for the 26 practices in Luton. That excludes COVID vaccination. So any practice doing COVID vaccination, it excludes those. So that's 96,000 for whatever the reason, excluding vaccinations. 70% of those were face-to-face. So actually in Luton, we had a higher face-to-face than other areas. And there is no target of 90. It's based on clinical need. And the Royal College of General Practitioners have not actually stated that percentage because it is so variable. But crudely, if I look at the England averages, it was about 60-40. So we have more face-to-face. So that was just the second question. The first question, the urgent treatment centre, I actually sent out a communication only because I became aware of there was a small outbreak where we had COVID. We actually didn't close the urgent treatment centre. I updated the website immediately, but we actually didn't. We thought we'd have to close it from 2:30 through till 8, but we didn't. So there has been no cessation of service at all at the urgent treatment centre for the last 6 months.
Thank you, Chair. Thank you, Paula. Thank you.
Anne.
I've just got to say, I do understand Councillor Pett's frustration, but I've got to also agree that we can't be charging people. I know we wouldn't be charging them if they attended, but I think we can't have people paying when we look at the NHS in any which way, even if they miss their appointments. I think what I'm desperately worried about, and maybe it's a party political point, but I think the NHS that's just been over the past years, certainly with the Tories, it's just been managed decline, really. And the problem is it not? It's not just people not attending their appointments, but we don't have enough GPs, do we? We have far fewer GPs than we actually need, and there's an issue with recruitment. And I think that certainly with my practice, we need GPs, and often sometimes there are locums or even senior nurses stepping into the role, and there is, am I right, there is an acute shortage of GPs nationally at the moment. And the other point that I would make is with my surgery, who's wonderful, got the greatest immense amount of time for them. If you have to cancel, you can leave a message, so you're not sort of stuck on the phone. I think most of us here have experienced 8:30 in the morning dialing and desperately hoping you're going to get one of those appointments. But if you're cancelling, you can leave a message, and so I think that actually helps. Thanks.
Yeah, absolutely. And that's one of the points that the practice managers have all done. So it's easy to cancel. So that's a really helpful point. I can assure members there would be never any suggestion of charging in any way. So just to give you that assurance on that element. And just at a local level, and this is good news, is that I know a number of you know Dr. Nina Pearson. So she chairs our workforce hub. We've done very well at recruiting GPs. And that's because we've done some really focused, targeted work on learning placement. So at a local level, it isn't as desperate, but I know at a national level, the matters are slightly different. But I will equally say that this is a BLMK initiative. It's very much about using our interprofessional working and learning. So, for example, we're using far more mental health skilled staff. As our first point in the, for example, the 111 service, you dial, and if you want mental health, you get redirected straight through. Equally, as somebody's mentioned, specialist nurses, but equally we've got there's something we call the additional role reimbursals. People may have seen that in some papers. The shortened term is ours, but we have really optimised community pharmacists. And we're equally optimising, for example, physiotherapists as first point. So really is developing that interprofessional team so that we are not centric to just medics with GPs, but of course they're key people in the team.
Thank you. Again, in terms of the paper, you mentioned about going to the pharmacy. As you know, most people, the first thing when they are not well is to the GP. So I'm not sure how much education we have done for people to know that they can go to the pharmacy or other health professionals if that has been opened up. So I think we need more education. I'm not sure. I haven't seen anything through my door to say, okay, now things are changing. Maybe it has. And it's been part of the junks I've just put in the bin. So if we can be specific to make sure that we do educate people that, look, in terms of primary care, things are changing. You have access to all this raft of health professionals you can go to and all that. Have we done the work? But if we're just expecting the residents to just go to, I don't think that's going to happen. People are, I'm stuck in my ways. I go to the GP as a first point of call. So I'm sure others will do the same. So have you done the background work to make sure that people understand that things are changing and this is how we are going to work?
And I thank you for that. And I think that's a very good point for colleagues that sit within the place board. So we obviously need to do more. So whatever we've done, it's not enough. So.
Thank you. I think so. One of the points about that is that we're shifting almost shifting the decision-making process onto the public rather than the primary care staff, aren't we? So you're asking someone to decide whether the seriousness of their medical issue and whether they should ring 111 or ring for a GP appointment. So I think this idea of educating the public is quite an important one. Any more questions? Okay. Thank you very much, Nikki. Item 10, the draft work programme.
Chair, if I may, the paper as per the pack, one change to report is that for the meeting on the 2nd of March, one of the items, adult social care delivery options, that has now moved to the April meeting on account of some of the timeline has changed. Otherwise, you've also got a new forward plan table before you containing the latest key decisions that's going before executive. It doesn't really make any major changes for you to be concerned about from the paper that was in your pack, but you have got one there for you to have a look at your leisure, and if you feel that we've missed anything, obviously you can always let me know.
Thank you. So I missed that. Which item's moving to April?
The adult social care delivery options. It's the one, the last but one on the list on page 24.
Okay, thank you. Okay. Anyone, any comments on the work programme? Okay, I think we can wrap things up. Thank you very much, everyone. Thank you for everyone who's delivered reports this evening, and